My name is Andrew Gilbert. I'm a research fellow at National Ageing Research Institute, and welcome to today's seminars in ageing. So I would like to begin by acknowledging the traditional owners of the land on which each of us are meeting today. For me, that is the Girai Wurrung people. And for NARI, our offices are located on the Wurundjeri Woi-wurrung people's traditional lands. I would also like to acknowledge the traditional owners of the lands and waters across all of Australia. I pay my respects to elders past and present and to all Aboriginal and Torres Strait Islander peoples, including members of the Stolen Generation. Firstly, a bit of housekeeping regarding Microsoft Teams. After the talk, we'll have some time for questions. If you have a question, you can submit it through the Teams Q&A function, which is a little icon you'll see in the row of icons at the top of this screen. It's two talking bubbles with a question mark. The chat function will be turned off, so don't try and comment in the chat function. Everyone's cameras and microphones have been muted by default. But if you'd like to verbalize your question, you can do so by clicking the raise your hand button, which is on the top bar of icons at the screen, and you'll be unmuted and visible. But if you do this, just beware, this meeting is being recorded and you will be recorded. So today we'll be hearing from Professor Hanan Khalil. Professor Khalil is a registered pharmacist, currently serving as the Associate Dean of Academic Partnerships at the School of Psychology and Public Health at La Trobe University. She has extensive experience in clinical practice research and education, working across hospitals, community settings, and academic institutions. Professor Khalil has published over 250 research and education articles and has been ranked among the top 2% of researchers globally by Stanford University. Beyond academia, she has contributed to national policy and regulatory frameworks, serving on the Therapeutic Goods Association Labelling of Medicines Committee to enhance medication safety. She is also an advisory member for the Monthly Index of Medical Specialties, and she is Editor-in-Chief of Current Opinion in Epidemiology and Public Health Journal. Today, Professor Khalil will be presenting Enhancing Palliative Care in Rural Aged Care, the Impact of an Evidence-Based Assessment Toolkit. So welcome, Professor Khalil, and over to you.
Thank you very much, Andrew, for this lovely introduction, and hi, everyone. I'm honoured to be here, and thank you for the invite to present some of my work on palliative care. The work that I'll be presenting today is just a snapshot of what we've been working on for the last probably 5 or 6 years. It's been I've worked in palliative care now for probably since 2018 up until now, published a few pieces of work, but this is the latest one. It's about enhancing assessment and early identification of residents in aged care facilities needing palliative care. So just a bit of background, rural residential aged care facilities now are increasingly involved in supporting older people, particularly at the end of their life. And the provision of targeted palliative care, including symptom control, is crucial for optimum care, reduction of stress for patients, carers, and healthcare professionals, and unnecessary hospitalization. We've published a lot of work in that area, and we've highlighted the importance of early identifications of patients needing palliative care assessments, whether at home or aged care, because that results in a better quality of care, reduction in hospitalizations and health services usage. we all know that there is a lot of funding initiatives have been supported by the Australian government, but it's highlighted significant gaps in the implementations of these initiatives, particularly the latest Royal Commission report that was published in 2022. It's actually shown that there was a few significant gaps in the management of palliative care. Examples of this being the late assessments and referrals, and that's also been identified in our research. In the home care setting, we found that lots of clients coming to even community health care centres come in really late, and there is not much that clinicians can do about them. We also noticed that less than 5% of residents in Australian aged care have advanced care directives, which is nowhere near what the number should be. And also recently, after COVID, we've noticed that obviously there is lots of staff shortages and limited training opportunities, which is really exacerbating many of these issues, particularly when it comes to palliative care. And this is even worse in rural areas. A lot of the research that I've done in this space is in either Gippsland or in the Mildura regions. However, a lot of these issues also are presented in metropolitan areas. So the rationale for developing a palliative care toolkit for early assessments came about because of the current model of care delivered to residential aged care facilities. They really rely on community healthcare centres to provide specialist palliative care services to these aged care services. Obviously, there is a huge problem with general practitioner referrals, specialist referrals, and working in partnership with family doctors and other allied health services. From the results that I will show in the halfway through my presentation, you will actually find that even though community healthcare services are supporting the aged care facilities within the region, it's nowhere near enough. And also nowhere near enough supporting these residents, but also there is lack of knowledge amongst staff in the aged care facilities about what's available and for palliative care and who they can tap into to get support from. So basically, this model relies on the ability of aged care staff to identify the need for anticipatory palliative care. At present, many residents are referred to very late in the end-of-life course, which can result in difficulties accessing coordinated care and respecting residents' preferences. So the gap that we have identified really in the body of work that we've published over the last 5 years is that there is a serious problem with early identification of residents by trained aged care staff. This is also in the home setting, but for today's presentation, I'll only focus on aged care. So there was an opportunity a couple of years ago to apply for a grant from ARIA and to really focus on developing some resources to support aged care staff with training and also with understanding what early assessments of palliative care needs include. So we've put in a grant, we're successful in obtaining the grant, and the grant was mainly about developing and implementing and evaluating an evidence-based palliative care assessment toolkit, which we called it PCAT, which I'll be referring to from now until the end of the presentation, to use by aged care staff, particularly for early assessment of aged care residents. We hope that the project really is going to improve the quality of care provided to aged care residents, improve medication safety, and also meeting residents' preferences, particularly at the end of life. When you see the toolkit has got a lot of resources, and it's not just aiming at providing medication care or assessment, but it's looking at a holistic and tailored palliative care management that standardizes care delivery and referral coordination into aged care facilities, and provided also education and training. We've developed the PCAT, or the tool, around most of the evidence-based guidelines that were available for through Care Search, Palliative Care Australia, and other pieces of resources that have been published in the literature so far. We used a collaborative multidisciplinary approach that involved specialists, pharmacists, community palliative care nurses, and residents and their carers to understand exactly the gaps that were involved in the provision of palliative care. So the setting for this particular project was Mildura, and if you're familiar with Mildura, Mildura is an outer regional city with a population of about 50,000 people living there. It's considered to be the largest local government area in Victoria, as well as the most remote. It's located about more than 500 kilometres from Melbourne. When you look at the population profile there, people aged 65 years and over make up about a little bit less than 20% of the population, and it's considered that about 20% of adults experience high levels of isolation there. Sunraysia Community Health Service is the only provider of palliative care services in the region, servicing Mildura and outlying areas of up to 100 kilometres away. With the community health services there, they not only service the aged care facilities, but they also service patients in the home needing palliative care. And so this project was conducted in Mildura and surrounds with the Sunraysia Community Health Care Service. They're providing care to 9 residential aged care facilities, about 600 beds there. So the way we went about this, we've developed a mixed methods study in design, and we've implemented the design into 3 phases. So basically, we had a baseline data collection and co-design PCAT. So the baseline data collection helped us to understand what the current problems are from the aged care perspective, the Sunraysia staff perspective, the clinicians involved, and some of the carers as well. We used both interviews as well as data collection from case audits records. With phase 2 involved implementation of the PCAT and training, and phase 3 occurred 6 or 7 months after the implementation of the tool, and we had evaluation of the PCAT and also the training that we've ran. Even though we initially started with 9 aged care facilities, only 5 of them contributed to the study, and 4 of we started with 5, but only 4 completed all phases. And I must admit that was a bit tricky at the stage where we initiated the study because of lots of staff turnover, and particularly also in the management of these aged care facilities. So we're very grateful for the 4 aged care sites that completed the studies for us. And we also had ethics approval from La Trobe University Human Research Ethics Committee, because we had to access residents' records as well as interviewing with some of these residents and their carers as well. So just to flesh out my last slide. So the phase 1, basically, we included, we've used the co-design approach, and a co-design approach, really, it's a fundamental collaborative step between the various key stakeholders to set up success and gather the experience, understand the experience, improve the experience, and monitor and maintain the experience and foster uptake of innovation. So we really had to get everybody who's involved in palliative care with us in our initial meeting to understand exactly what we are going to help them with, what their issues were, and to get all of us on the same table, on the same page, to make sure that they were all happy, every staff member that we've engaged with, happy with the actual project and whether we needed to do any modifications. Phase 2, again, that was, we included extensive training of all the staff employed at the participating HK facilities. And also the training was provided by staff from Sunraysia Community Health Service. It's actually, that's really part of their work to provide training and education to staff. But there was also additional training involved with this particular project because of the tool that we've developed and the specific problems that that the staff experienced as well and wanted indicated that they wanted training in. And the last phase, as I mentioned, there was an evaluation of that. Okay, with data collection, with the quantitative data, we've audited the records of deceased residents from each HK facility. We've also evaluated their advanced care planning, medication availability, family meetings, and staff training. So we created a survey that's used by the modified survey used by the Palliative Care Consortium from the London Valley, and we've incorporated additional questions based on some of the research that we've done previously. The qualitative aspect of the project included interviews with clinical staff and also interviews post-implementation regarding staff feedback about the experience of the project. We had several education training, particularly around the program of experience in the palliative approach, which is the PEPA workshops. It's widely available on the website. And also we had targeted training sessions on different aspects of palliative care that were indicated by staff that they were needed. To implement the project, we've used CCC implementation framework or model, and it was important for us to use an evidence-based model for implementation of this project to ensure its success. That's a framework that I've published a few years ago, and it's been used in several of my projects, as well as other researchers' projects. It's been cited multiple times. It's a simple framework that includes really aspects of consultation, collaboration, and consolidation, but it provided us a good systematic framework about how to implement the project in the participating organizations. In the consultation phase, we engaged a palliative care consultant from Monash Health. We had to have, obviously, a palliative care physician with us, Professor Peter Poon. He's the Director of Palliative and Supportive Care at Monash Health, and he's been working with us in palliative care projects since, again, 2018, since I've started to work in palliative care. So it was important for us to have a good team, consulting with good team, good knowledge, and also making sure that everybody knew the working styles of others. Obviously, we had staff engaged from Sunraysia Community Health Services to run the education sessions, to understand a little bit about the logistics and the workings of HK facilities and who's the staff to reach out to. We had to reach out to HK staff from the participating sites as well, particularly the management, because not every HK facilities that we approached had the capacity to be involved in research. Some of them were involved in a lot of research. Others really had a lot of challenges in being part of research. So they wanted to understand exactly what's in it for them. And we obviously had practitioners and academics in palliative care in the consultation phase. In the collaboration phase of the project, we made sure that we had defined roles and we had organizational support and agreement about the roles of each of us included in the project. And we needed to make sure that we had good reporting mechanisms as well for touching base with any challenges or any issues that we had to deal with in the implementation of the tool and provision of the education. The consolidation stage also was quite important, and it was really about ensuring that whatever tool we've developed or resources, it's actually embedded into the policies and training. And I'll talk a little bit about this later on, about what we've done in that space. This is just a summary of the issues that we have identified from the baseline audit. So I remember what I've said. So basically, we wanted to understand the landscape of the problems that the aged care sites had. So the gaps that were identified included undertaking difficult conversations with residents and carers. It was very challenging with many of the staff there. There was also some of the staff highlighted the fact that there was lack of GP involvement in advanced care planning. The regular review of the residents also wasn't happening. It was only completed in about 70% of all cases. And mind you, this is really the overall review. So some aged care sites had less than that, and others had more. Resident enrich in the previous 3 months only took place in 50% of the cases. This is really support from the Sunraysia Community Health Service. So even though the aged care facilities knew that they could reach out to the Community Health Care Centre palliative care support for their help, but that only happened in 50% of the cases. Family meetings, again, wasn't happening for all the cases, and end-of-life care was only commenced in 40% of the cases that were audited. Pain management, it was good to see that pain management was completed in 90% of the cases. However, it's important to be mindful that the 90% of the cases meant that was irrespective of the timeline. So pain management, it was a tick in the box whether pain management was prescribed or not. So obviously, ideally, pain management would have been completed in the advanced care planning and right at the beginning, but in 90% of the cases, sometimes even 1 or 2 days before death, that actually occurred. So that would be an over-reporting of the pain management as well. It was also interesting to note that emotional support and spiritual support and bereavement support were not always completely reported to or even discussed in those cases. I just want to go through some of these very briefly interview results. So as I mentioned before, we did use mixed methods. So that was the baseline. That was the quantitative data. With the qualitative data, when we've interviewed some of the carers and staff, we had really mixed messages. So some staff highlighted the fact that external GPs have found them more accessible and provide timely care. Some staff also mentioned that because they had problems with accessing GP to writing scripts for pain managements and other anticipatory medications, so they ended up using the Victorian Virtual Emergency Department ED telehealth, and that's been very useful. But other aged care sites really found it very frustrating to get a hold of GPs and prescribing medications needed. Some of the aged care sites found also that palliative care services provided through the Community Health Care Centre very prompt, very accessible, and very supportive. So that was very good to see. There was also a connection between some of the staff, particularly the staff that have been there for a long time in aged care, in the aged care facilities. They actually knew some of the residents well, and they knew how to. They connected with them very well through their past experiences with social functions and all of that. So they sort of had a good rapport with them and good knowledge of their conditions. And also, some of them also reported on some of the educational sessions that were provided by Sunraysia Community Health Service, even though they were not very often, but they actually said that they were actually very useful and very helpful to them. So that was what was working. What's not working really is, again, some of it is more or less the same, like what I mentioned before. So reluctance of GPs to visit HK sites, lacking knowledge of GPs about the process of prescribing anticipatory medications or medications that are useful at the end of life. Nurses, so there was lots of nurses, some of them were very young, but didn't have experience in palliative care and really were out of their depth in managing these patients. There was also some of the challenges around end-of-life resources, not keeping up with best practice. And also some of the staff mentioned that it was really hard for them to initiate conversations about what's end-of-life care and what's expecting and advanced care planning and all of that. And also some of the family members mentioned that they were really reluctant to discuss palliative care before and during their residents experiencing end-of-life care as well. So there were some challenges that we had to work with. Again, some more of that. And for the sake of time, I'll just skip over this because I did summarize it here. So the summaries from the interviews that I've just mentioned. So we've noticed that there was a lot of new staff to aged care, lacking experience and training in palliative care. End-of-life discussions, initiating that discussions was really challenging for some of the residents and the family members and even the staff. Keeping up to date with evidence-informed best practice, again, was very challenging with some of the staff there, and the GP reluctance to visit HK sites as well. Again, all of this actually have been documented in the literature previously and from our research, other research internationally, but also this research as well. There was also opportunity for documentations to be improved and streamlined through online systems. As you may know, some of these aged care facilities didn't have any medical records that staff were able to enter information on them directly. So they were still relying on bits and pieces of both paper-based documentations as well as computer-based documentation. Now, once we have identified all the gaps through the baseline audit, the interviews, we had a clearer understanding about the needs in the needs for the toolkit and the needs for the educational sessions that are needed for the staff. So we had another meeting with the staff, including the palliative care physician, the staff from the aged care facilities, the staff from Sunraysia, and also we had a representative for a consumer input in there. We've put together a draft of all the educational needs that had to be provided, and also we have highlighted some of the resources that need to be put in the toolkit. So we focused basically on developing strategies to individualize the palliative care approach. We've also focused on the role of the various disciplines in managing common problems faced by people with limiting life illnesses. We also recognized that there was lack of knowledge or base scope of practice regarding optimal palliative care. So some of the sessions were really based on providing the basics of PC care, palliative care. And we've also emphasized the importance of having good communication skills, particularly when aged care staff were required to initiate difficult conversations with residents or carers too. We also had to highlight or give information about the other additional network of support that aged care and staff can tap into to support their residents. And also we had to make sure to develop an understanding of the role of the mentorship in palliative care to embed into the organization. So these were the basics upon which really we built the toolkit and also the education sessions that were subsequently provided to the participating aged care sites. So the staff that were involved in the educational sessions. We had about 62 participants. In fact, I think we had a little bit more than that, but not all of them participated in the survey. So that was a good turnover from about 4 sites, as well as other staff from within the Sunraysia Community Health Service. Most of them, as you can see here, they were really between 25 and 44. Some of them were 45 to 54. A lot of them were Australian, but also we had other nationality ones. A lot of them were registered nurses, but also we had other senior managements as well. And we had 15 personal care assistants out of the 62 that filled in the survey. Regarding the years of experience in working in rural and remote regions, again, it varied between less than 1 year to some of them having over 20 years experience. Now, we've asked them about the educational sessions that we provided over a few times, and most of them agreed that it was quite useful and that it helped them with their knowledge, increased knowledge, and that they would recommend them to other colleagues of theirs. We've asked them if what else if they wanted in the sessions. So some of them indicated that it was excellent, it was great, they were happy, satisfied, and enjoyed the training session. So really, we made sure that the sessions met the needs that were initially identified in the baseline gaps that we've had. Now, this is just our overall findings, which I've already mentioned to you before, and for the sake of time, I'll just skip over this one. But I just want to highlight a little bit about the what we've done after the implementation of these sessions in the toolkit. Now, we were quite interested in a few aspects that we've had baseline audit for, and particularly the commencement of end-of-life care planning, because we did identify that was a gap. Initially, so all the issues that we have identified as gaps, we've reported on them in our post-implementation. We had about 5 to 7 months post-implementation, depending on because we had aged care sites starting at different times as well. So we've reported on the commencement of end-of-life care planning, the availability of anticipatory medications, provision of psychological support, spiritual support, and staff confidence, and all of them have improved after the implementation of the toolkit and the training, and including the staff confidence as well, which was really pleasing to see that we've captured the gaps that were initiated by the staff, and we've actually successfully addressed them in the toolkit and the resources that were given to the sites as well as the educational sessions. So what does the toolkit include specifically? It included information on the palliative care approach, also information on the palliative care needs round, information on recognizing and responding to deterioration, and particularly also the SPICT tool. Good communication practice between residents and carers, symptom management based on the palliative care standards, a little bit about how to talk about dying and going through bereavement processes as well. So this is what the toolkit and the educational sessions pretty much focused on. So overall findings, we found that the TCAT, the toolkit, improved key aspects of care, particularly medication management and staff training. There was definitely evidence of family involvement in the care planning, and also there was still some gaps remaining in the health services use and the GP involvement. That sort of still, we haven't solved that particular problem, maybe because it's because of the fact that it's a rural area. But we've also highlighted the options of having additional GP support from the Medicare from the clinics that were surrounding the community health service as well. Now, obviously, there is always a challenge to sustain long-term palliative care training and implementation, and that's not just from our project, but also the other projects. When you develop something that's quite successful, you always want to make sure about how to sustain that. And we know that with the education and training, it's not long-term sustainable unless if it's embedded into at a system level in the aged care sites, and we've tried to do this as much as we can, particularly with the Sunraysia Community Healthcare Service providing responsible for providing educational training to these aged care sites as well. Now, the strengths and limitations of this particular type of work is that obviously the strength on it lies in the fact that we've identified a critical gap in the rural palliative care delivery, and we try to set up evidence-based design and approach to collaborate with our stakeholders to ensure that we're providing solutions that work, solutions that have evidence that worked, and also in collaboration with staff and residents and also families. We've shown that the resources, the toolkit, improved care delivery and staff confidence. Obviously, the limitations of this particular project lie in the fact that we only had 4 aged care facilities completing the study. The 5 to 7 months post implementation, it's relatively short. We would hope that maybe to have another round of maybe evaluation in 12 months time, but because of the grant and the fact that we needed to report on the evaluation of the project, so we were only limited to 7 months, 5 to 7 months post implementation results. We had to report back to the funding organization, also to the university, and also the fact that 1 facility withdrew from the project. So even though we had 9 facilities that we could tap into, unfortunately, with the lack of staff and shortage in aged care in rural areas, we only had 4 participating in this. So some of the recommendations out of our work included standardizing the toolkit, adoption in rural aged care, continuous training of professional staff, not just one-off when we have funding and when we have a project like this. And also we'd like to expand to urban settings to see whether also it's similar issues and to assess long-term sustainability. There is also early PC referral. So this is very important because that was really one of the problems that we've identified. The referral need to happen early on at the beginning so that residents and patients can have the best quality of care provided to them. I just want to acknowledge at the end the participating aged care facilities and staff, and I want to acknowledge the funding organisation, Sunraysia Community Healthcare Service, and Aged Care Research and Industry Innovation Australia, that have provided us, both organisations provided us with funding that helped us to implement the project. This is the paper that was published at the beginning of the year, reporting on the project and what I've just talked about, if you'd like more information on this. This is the end of it, but I would like to actually say a little bit more about what we're doing in that space. So ideally, we're hoping to convert the PCAT into a digitalized format. So there is a grant application that we're writing at the moment about converting the toolkit into a digital app accessible format. So more aged care staff can use it, and it will be widely available to everyone. So hoping to get the funding for this project so we can run it into other organizations. We've already approached other aged care sites in other interstates. They're very keen on trialing this, and we've got at the moment about 7 or 8 sites wanting to be part of this second stage of the project. So thank you for listening. Thank you for being here, and I'm happy to take any questions.
Thank you very much.